Okay, good morning, everybody. It is 10. I'm going to go ahead and get us started for the sake of time. We have a lot to cover today. So I am going to kick us off. So my name is Candace Bailey. I am the HCBS Division Director within the Office of Community Living. And today we are going to continue our discussion on Nurse Assessor. This is our last large meeting before we officially launch. It's really, really exciting. And we have some really great updates. We have a lot of content today. So bear with us as we really just flow through a lot of this information as quickly as possible. Next slide, please. All right, so just a few little helpful reminders here. We are recording this meeting, so it will be posted for everybody. So if there's anybody who misses part of it, who wasn't able to join, not to worry. This will be posted later for everybody to review as necessary. Please feel free to use the chat feature to ask questions. We will get to those as best as we can. A lot of questions come in that way. We are not able to get to every single question, unfortunately, but we do capture every single question from the chat, and then we post it with a response, a written response, after the fact in what we call our listening log. As of the last meeting, those are all up to date, and we are, gosh, it was 411 2 meetings ago, so it's going to be pushing 500 at this point, questions and written responses that we have posted for everybody. But that just means you guys are incredibly engaged, and we really appreciate it. So feel free to take a look at that. The slides will be posted or are posted online. We'll also post them here in the chat so that folks can download them. If you are listening by phone, please press *6 to unmute your line. But before that, please press *9 to raise your hand so that we know that we can, somebody is waiting in the queue and we can call on you. You can also have closed captioning to help you, should that be necessary. And then obviously, please check out our website if you have additional questions. And then there's just a lot of information on there. So I highly, highly recommend that you bookmark that page if you are very interested in this project. Next slide, please. All right, as always, we like to start off and ground ourselves in our mission, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money in healthcare and driving value for Colorado. Next slide, please. All right, so the purpose of today's meeting is really to communicate and engage with stakeholders about the Nurse Assessor project, which is an OCL priority project, just to kind of let you guys know the next steps and answer questions and provide a lot of information to you all around this project. Next slide, please. Here's our agenda. As you can see, it's really busy. It's really long because we had a lot to cover today. So first, we'll recap our meeting from last month. We will go through a couple, and I will show a few screenshots of the Qualitrack system. So this is the system that the Telgen vendor is using and that folks will log into to submit referrals and things like that. So we will have some screenshots of that. We're going to talk a little bit about how points from the acuity assessment, from the acuity tool, translate into time, because there's been a few questions about that. We're going to go through the finalized criteria, of which you all helped us finalize a few meetings ago, and we walked through some examples and asked for some feedback, and so it was really, really helpful. So we're going to walk through that finalized criteria. We're going to talk about some transition timelines and then post-implementation monitoring. Another big component that you all have asked for several times is, what are we going to be monitoring? What are the metrics we're going to be looking for? We're going to walk through all of that on that slide. And then we'll go through a few other frequently asked questions, because we did that last month and it was really helpful. And so I'm really excited to have a few more of those. These are also posted online as well. If you don't have time to scroll through that really extensive listening log, we have pulled out some of the FAQs and have a whole FAQ section on the Nurse Assessor website. Next slide, please. All right, so just a super high-level brief recap of last meeting. We went through an overview of the processes. So in particular, the process for a case management agency and how they are going to walk through and do their flow for a health maintenance activity member. So somebody on CDAS or IHSS that needs HMA, and what that process looks like. And so there's a flow of that and walks through the step-by-step process. We also walk through the home health agency process for home health agencies that need to submit a PAR for long-term home health services or private duty nursing services, what that process looks like with the nurse assessor on the front end. That, again, all of this is posted online. So if you missed last month, please go in and check that out so that you can see the process that we walked through. We also went through several frequently asked questions last month. Again, that was another really great opportunity for us to answer some questions that many of you have all at the same time. So that was really lovely. Excuse me. And then we talked a little bit about some post-implementation feedback. Here's some resources for you. There's the recording from last month, the listening log, which I think has already been posted in the chat here. And then the website again. And I think probably all of these have been posted in the chat. And as they come up and as questions come up, we'll repost them in the chat just in case folks missed it. All right, next slide. All right, so timeline update. As you all, I know, have heard, but just to reiterate, we have had a change in our timeline. The implementation of the actual Nurse Assessor Program and the Skilled Care Acuity Assessment, if you recall, they go hand in hand, has actually been delayed to August 1st, 2025, which is not very long from now. We released an operational memo. It's linked there. We can have it posted in the chat as well, outlining and detailing the reasons for that. But really and truly, the system wasn't quite ready. It was close, but wasn't quite there. And we really committed to only operationalizing and launching this program once we were fully confident that everything was ready to go. And so we went ahead and delayed it for a month. So with that, the system actually is going to be ready before August 1st. So what we have decided to do is we're doing what's called a ramp up period, because can't do soft launch because we already used that for something else. And so, yeah, we always have to come up with a different creative way of titling something. So ramp up is what this one is. So the ramp up period, which actually starts July 21st, which is just in a few weeks, which is really exciting. And what this is this is going to be a small cohort of identified individuals that Telgen is going to be starting the assessments for. This will be for adult long-term home health and private duty nursing members that currently already have PAR, because if you recall, those PARs are required, that those PARs are going to expire in that timeline of August 1st through August 10th. And so to kind of help mitigate any concerns around the timeline with the prior authorizations and things like that, we're actually having those folks go through the ramp up period starting July 21st so that we don't worry about that timeline. And then it's kind of a slow start too for Telgen. Agencies going to try. We have a lot of different agencies that are actually a part of this, which is really exciting. This will allow all these PARs and all of the processes to flow through for that 8/1 through 8/10 start date for those prior authorizations. The agencies have been outreached directly on this, and then there's more information later. I did see a question come up if there are any CDOS members, HMA. No, because those start the beginning of the month, and those August and September continued stay reviews, CSRs, were completed previously. And so the ramp up period is going to be solely for those with the adult long-term home health and private duty nursing PARs that are expiring those first 2 weeks of August. All right, again, more to come on the timeline. This is just a little preview. Okay, the next slide is actually a screenshot. We had so many slides that we decided to cull them down and actually not have our transition slides in between. So apologies if you feel like we're jumping. I kind of feel like I'm jumping, so just bear with me. Okay, so here's a screenshot. One of the things we've heard loud and clear is you all really wanting to know, what does the referral form look like? What is it going to be like? This is what it looks like. This is a screenshot directly from the system that Telgen has built. It's very simple. It's very straightforward. A provider can submit it. A medical doctor can submit it. A family member, a neighbor, like anybody can submit this form, which is really exciting. And it will actually, you'll have to answer the question, are you a member? Things like that. So it's really exciting, and these have drop downs. And so if there is something, for example, my case management agency where you don't know your case management agency, there's an option for that. Oh, look, Katie just asked that question. So there's an option in that drop down that says that they don't know if they don't know. It's just helpful information if somebody does know. So the next slide, please, is the referral form continued. So it's, obviously it's on a screen, so it scrolls. And so we had to break it down into a couple different screenshots here. But it's, as you can see, language preference, somebody can request an interpreter right in the beginning here in the referral form, which is really exciting. And then there's that big giant submit button. So this is really, really exciting. This is what it looks like. It's very simple. Very straightforward. Cassie, should we go to questions or should we move on to the next screenshot?
Let's go ahead and answer some questions because they're specific to this page. So the first one is, what does the question authorizing sharing of what information to? So really this is saying we'll share the results of this assessment with whoever this person is selecting. So it could be a case manager, a home health agency. So this is more of the self-referral form. So as a member, I want to submit this referral for the nurse assessor. And if I want it to be shared, I could share it with a family, whoever it is I'd like to have the results of this information shared with, that's who you would put down. And it says if they click yes to share, yes, you would specifically say, who would I want it shared with? And that if you say yes, it opens up into a line that says, who would you like it shared with? We've got a question of, is that a HIPAA waiver? And no, it's not a HIPAA waiver. It's not waiving HIPAA. It's just saying if someone wants it. Katie asked, and then sorry, Candace, one more.
Sure.
Does it refer to the member's preferred language or the person submitting the form?
The member's preferred language. So this is the referral form is specific to the member and their needs, which would include their preferred language.
And one last question from Molly is Qualtrics set up to indicate whether this is a duplicate referral? It will.
Yes.
So once a thing is submitted, Candace, if you want to talk about that process.
Yes. So Qualtrics is actually going to has all the information. So let's say 3 different people identify. You have a RAE case worker and a case management agency, and then also family member that identify somebody needs some skilled care. And all 3 go into the Qualtrics. The Qualtrics system is actually going to notify somebody that there's already a referral submitted, and so therefore a second one, it will not be duplicated in the system, which is really nice. All right, let's move on to our next screenshot, which is another request that we have received several times, which I completely appreciate. So this is a copy of the recommendation letter. So this is, again, it's a screenshot, so bear with us. I know the formatting isn't lovely, but this gives you an idea of what the recommendation letter is going to look like. And we have actually a couple more, 2 more screenshots after this one, because the letter goes more than 1 page, just so you know. So there's more information on this letter, but this gives you an idea of what it's going to look like, how it's going to flow. We have, the hours broken down, next steps. Jude, if you have questions, I would suggest, go ahead and raise your hand. Let's have some conversation too. That would be great. But let's go through the rest of these screenshots and then I will call on you. So next slide, please. So this is, again, after the next steps section, we have this box that provides an additional visual for folks. I know for me, I like tables. Other people prefer paragraphs, things like that. So this is a way for us to show in a couple different aspects. And then it outlines who this information went to. So if you selected, you wanted your case manager who happens to be Braden Farrell, that would populate here from the referral form. And then one more slide for me, please. And then again, the recommendation letter continued. There's explanation, and then a section down here, if you have questions, who you can contact, there's a phone number and email, all of the things here. All right. There are lots of questions, which is exciting. So let's go ahead and start with yours, Jude.
Okay, can you go back to page 9, like the beginning of the recommendation letter?
Sure.
Thank you. For where it says certified nurses aid 56 hours per week, is that skilled hours or does that also include personal care hours?
Nope. Certified nursing aid is only skilled hours.
Okay, so this person has a lot of needs because 56 hours means they pegged the point check. They pegged it, right? So the odds are, I would like to meet the individual that earned
This is obviously a fake
a
case.
Okay.
Yeah, this is obviously a fake case.
Okay, that's part of what the questions were. The The private duty nursing services is 17.5 hours. That's from the calculations done on the PDN tab in the tool.
Correct.
Okay. And then, so then you're saying that the 56 hours is the CNA modifier tab in the tool.
It's the CNA task, yes, in the tool. So it
Right.
populates over. So the tool hours, the assessment itself populates over to this. Again, I just want to be clear. This is not a real individual. This is a completely
No.
fake individual with hours and everything. So I just want to
Right,
make sure
that's
that name
part of what
Stacy
I'm-
is not anybody they know.
No. That's part of what I'm trying to reconcile here, because there's no place in the PDN tab tool or the CNA modifier tool where it ever mentions health maintenance activities. So where did the 44.25 hours per week come
Health
from?
maintenance activities is a skill care activity. It is not separate and apart. So those tasks would populate in from those skill care activities based off of what the member chooses. So this is just showing that that the tool will populate these.
There's no place to populate HMA. That's what I'm confused about. But part of what I've been trying to understand is, will this number for HMA be the sum of the PDM hours, which would be, if for this example, 17.5, plus the CNA hours, which for this example would be 56. To me, that's what the two tabs on the tool have said. These are the skilled health maintenance activities that you show you require hours for. And so I'm asking, is HMA the sum of PDN and CNA modifier?
I think Cassie's going to jump in here. Yes.
Yeah.
The answer is yes.
Yes, it is. So I get the math may not be adding up. This was our bad for putting in numbers instead of just blanks. But that is how it is. It's those totals of the CNA or PDN tasks coming together into those HMA hours. So yes, that is the answer to your
That's what would populate there. So when you're going through the tool, when you're doing it, there's nothing currently that indicates that that sum is what's going to populate the recommendation letter. So that's what I was looking to clarify.
Understood.
And so the other tab, the nursing visits, does that have any additional hours that it adds to the HMA activity hours?
Yeah, so anywhere that there is points and time that are calculated from either the PDN, the nursing visits, or the CNA would in total come over to the HMA hours. Because again,
Okay,
that's
so
a
it's
representation of a blend of what could be RN or CNA tasks. So those things together come in to equate that. You're right. You don't score HMA. It is a translation from those points over to HMA.
okay, so that's a big clarifier. Thank you so much for that. That it's all three of those tabs contribute to a bottom line of what will be populated for HMA on the recommendation letter.
You are correct.
Okay, and then my second kind of question is, when the nurse assessor is going through this with an individual and they're looking at bathing, okay, and they're going through it with the member, and there may be some bathing that's skilled. Bathing could be skilled or unskilled. So I guess what I'm asking is, when you're going through it with the assessor and the criteria for it being skilled says, well, I can't give you any time for that here on the skilled nurse assessment because that's a personal care item. Will they be simultaneously be filling out the direct care services calculator? I mean, you don't want to lose track of those hours that the nurse assessor has just told you deserve these hours, but they're not skilled. So how does that get registered?
Yeah. So if there are unskilled hours and unskilled tasks that are identified during the assessment, then yes, the nurse is actually going to be filling out the direct care calculator at the same time so that they don't lose track of those unskilled hours. However, to your point, bathing is either skilled or unskilled, right? And so
right,
if there
there's no in between, but I just didn't want to lose that category.
Yeah, exactly. And so, if there were, let's say there's 3 tasks, let's just stay with me for a second. Let's say there's 3 tasks for bathing. that are skilled and 2 that are unskilled, it's still a skilled task because it's one task. And so the nurse is going to make sure that that time, and if they have to add time at the end because for whatever reason that didn't capture 30 minutes for a bath, and again, I'm making up numbers, nobody get mad at me for the numbers I'm throwing out there. It didn't account for the full 30 minutes that are necessary. It only counted for 25. They can up it to 30 and be like, and explain, here's why. It's because a nurse isn't going to leave for part of the bath so somebody else can come in, because that's not how it works. It's either skilled or unskilled. Yes.
That's part of what I was trying to clarify too, because like, for example, I was looking at dressing and allows, the calculation part of it for skilled allows for 15 minutes for dressing, which is pretty quick for me, even 15 minutes for dressing twice a day. So if I have a member, my daughter often has accidents and soils herself or whatever, and it takes 30 minutes to dress her a time, and I have to dress her 4 times a day, it's fixed in the calculations on the spreadsheet. You can't expand the time there. So then down in the comments somewhere, will the nurse assessor say, this person requires twice as much time to dress and twice as many times a day to dress? It'll be like in the comment section, or?
Yeah, there's an additional section at the bottom, and I don't know the exact title of it. Somebody's going to tell me here in a second, but it allows the nurse, because part of those assessments, right, is a conversation. And so they're going to be walking through and talking about all of these different things. And so if the assessment says you only get to dress twice a day, but somebody needs to get dressed 4 times a day, the nurse can actually add that information in, and including additional time for that. So there is that wiggle room, because you have to, right? Not everybody is the same. And so you can't have something that's exactly only this many times a day is all one person needs, because that's not real. And so there is the additional consideration section that the nurse will absolutely use and fill out to add the additional time if it's necessary.
But the clarifier is, it's not a calculation. It's just a notation in a comment type section that they will have to go through at the end and say, oh, for bathing, they got this much more time. For mobility, they got this much more time. See where I'm going?
Yeah,
I'm trying to figure out how it's going to reconcile at the end.
Yeah, yep, understood. And that makes total sense. So the question is, just want to repeat it to make sure I'm understanding it, okay? So the question is, this additional comment, let's say they say, this individual needs an additional 30 minutes. It is not part of the calculation and would have to be added at the end by the nurse. And then your question, I'm assuming from there, is if the nurse adds it, is it then going to feed into the recommendation letter? Is that accurate? Did I say that right?
It would have to be, well, yes, exactly. Because I feel like it's being captured in a comment section, and I'm the numbers nerd. It's not captured in the calculations. So I'm wondering how the reconciliation is going to happen before you populate any of these recommendation letter fields. And so that may be a system type question, or it may just be written in the training that the nurse goes through and calculates it all up and adds it in somewhere. I don't know, but I just haven't seen anything on that.
Yeah. So Cassie, you may want to jump in here, but my understanding is in that section, it actually does pull that number and add it into the calculation. So then it then can get pulled into the recommendation letter from the system piece. Cassie, did I state that accurately?
You are correct. I believe the box was titled additional considerations. If my memory serves me correctly, but yes, that calculates into the total of points, which then goes into hours, which then feeds into the recommendation letter.
I didn't see that. I'm not seeing that at all when I tried to use it. And so that's my concern. It randomly, when I did it, it randomly added an extra hour, and I hadn't put any comments in, or I hadn't done anything like that. It didn't allow me to change that 1 hour to like 4 hours.
Okay, maybe Jude, we can walk through one offline with you.
Yeah, that'd be great.
If that works, just to make sure we're all on the same page. Okay, that would be great. If you want to follow up.
And then my final question is, do you know if the interim direct carrier service calculator is going to hold open space for manual HMA hours calculations on the direct care services form? Because at one point in
Yep.
time, they
Great
said
question.
you could go back to your case manager and go through the task worksheet again. Now the DSCS, whatever, and calculate your HM hours if you see a big discrepancy from
Mhm.
the nurse, what you're getting from the nurse assessor form. Is that still part of the interim plan?
Yes, that is still the plan, that they could go through the case manager. And the question I think is, does the interim direct services calculator have a place to make adjustments, was the actual question. Is that right? Okay.
Yeah.
Cassie, does that still have the place to make the adjustments within the interim
does.
calculator?
It does. And so we, as we are rolling out case management agency training, one of the things that we've included is we are updating and posting the a revision to the direct care service calculator that has an area for deviations from the nurse assessment is what we're calling it, for health maintenance activities, and where that's kind of logged within that spreadsheet, and the case manager all parties agree to this and attest to this is what they're doing. So that is now specifically in that DCSC for that purpose.
Okay, perfect. Thank you.
Thank you for those questions, Jude. Really appreciate it. Katie,
Hi there, can you hear me?
we can.
Wonderful. I have two specific questions about the recommendation letter.
Okay.
The first was, I didn't see anywhere that it indicated how you can get access to the copy of the assessment and how the boxes were filled in, which I know is like absolutely necessary to make sure folks actually know what the assessment looked like. I didn't see any language about that. Can you help me?
People will get a copy of their assessment at the same time as the recommendation letter. And so your question is specifically how it comes with the recommendation letter. So they don't have to ask for it separately.
Okay, so every person who gets a recommendation letter will get like a printout of all the boxes, the Excel spreadsheet, the way it was filled in, the comments.
Not necessarily a printout, because not everybody is choosing to have their recommendation letter printed to them and mailed to them. So that they would choose that. If they were to choose that, they would get a printout of their assessment. If they choose to go into a portal to access it, it will automatically be there too. It'll be part of their file that they can access.
Okay, however they get the recommendation letter, they will
Correct.
also receive it. Okay, wonderful.
That is
That's
correct.
helpful. And then the second piece was, I noticed it talks about you can get another assessment in a year, or if you have a change in condition.
Mhm.
Is there going to be any language about like, hey, the comment the nurse made isn't actually accurate. There was a mistake made. I would like to be reassessed. There doesn't seem to be any mention of like, wait a minute, you missed this, you put this in incorrectly, like human error happens. Doesn't seem to have any indication here that I can say, wait a second, the nurse's comment here is actually about somebody else. It's not the right person. There was a mistake made. Is that going to be included in the recommendation letter? I think the noticing, like the letter that you receive, has to be very clear on what to do if you see something like, wait a second, that's not accurate.
Looking to see the next screenshots. Sorry.
I just don't want people to see this and go, oh, I guess I have to wait a year.
So if there are specific questions about the assessment, there are ways to reach out and contact folks. So let me see. Yeah, if you have questions about the skilled care service, yeah, you can send an email to us directly, the home health inbox, or it's on the third screenshot.
So there's no mechanism for like, I need to contact the assessor that I had and say, hey, there was an error here. We have to go through the home health inbox and sort of wait for that to go through.
Paul, well, the home health inbox is checked multiple times a day, so it's not like folks are waiting a long time for a response. Paul, can you scroll down through 2 more screenshots? So questions, too far. You scrolled really fast. Thank you. So this one is there is a contact to reach out directly to Telligent. If you see there's an email, there's a phone number. So there is a place to reach out directly to Telligent as well. It looks like Cassie has her hand up and wants to address this as well.
Yeah, Candace, I think I was just going to mention that I think part of the beauty of the way this program is that this is not the authorization process. So as we just talked about with Jude, if there is a discrepancy that is perhaps missed, that it is only marked 30 minutes for a bowel program, but it really takes you 45 minutes, the case manager has the authority to make a deviation from that recommendation and through the authorization process. The same goes for the skilled care side with long-term home health and private duty nursing. If the member or the home health agency feels like there is an inaccuracy there, they can request hours that are different from the recommendation if there is a justification there. So if there is documentation that shows that it takes this member 45 minutes and not a standard 30 minutes for a bowel program, they would make that request in the prior authorization, and then it can be approved during the medical necessity review. So there's not an end all be all. If you don't agree with that recommendation, there are other avenues to see that you can seek to get those needs met if you don't agree with something from the recommendation and the assessment.
Thank you, Cassie. And another piece that is really important is the nurse is actually going to go through the assessment and the results at the end of the assessment with the member. So they will walk through kind of what the assessment found, what the acuity tool determined, all of the things. So all of that information, they're going to walk through that at the end of the assessment so that everybody is clear and there shouldn't be any surprises. I hear you, Katie, we're all humans, right? We all make mistakes, and that there is still an opportunity for some sort of mistake to occur. But as far as the information that's in the assessment itself, that should be pretty straightforward. So great questions. I'm going to move us forward because we do have a lot more slides to cover, and I do have a lot more hands up. Go back, please. Sorry, I'm not going to move us forward in the presentation yet. I want to take a couple more questions specific. Sorry, Paul, that was not clear. On the recommendation letter, because I know this has been a point that folks have really been asking about. So I want to provide the opportunity for a few more people to ask questions, and then we can move forward. Megan, go right ahead.
All right, thanks. I have 3 questions.
Great.
So one is sort of echoing a little bit of what Jude was getting at. I appreciate the answers to that and that these numbers are not actually accurate, that it is a sum. My lingering question on that is about where there may be potential overlap between those 4 numbers that are listed and how they're going to manage that. So particularly between skilled nurse visits and private duty nursing, for example, giving medications might have been documented in both of those, but then that would be duplicative if you just added all 3 of those together to get HMA. So how is that sort of piece negotiated is one question. Do you want me to do all 3 or do them one at a time?
Sure, go right ahead. We'll roll through them and then we'll see if I need to phone a friend.
Okay, and then my second question is how are home health agencies and or case managers supposed to take what's in the nurse assessment report and translate that into actual care plans that can be built upon and documented? Are they supposed to read through it and sort of piece through and try to calculate, okay, I think bathing actually ended up to be this many hours, medication ended up to be this many hours, or is there a way to kind of directly go from this report to that sort of care planning piece? And then my third question is kind of reiterating what Katie said. I think that if either this assessment, this recommendation holds a lot of weight, which I hope it does if we're spending millions and millions of dollars on it and it's a long process and if it holds a significant amount of weight, then there needs to be a process for saying the assessment I got was garbage and we need to do this again without it taking an entire year. And hopefully those would be few and far between. And if that's not an option, then that tells me that this assessment doesn't hold much weight and it's not really worth much. And so it's sort of, I feel like we're playing both words. It's really important recommendation and it's not really important at all that anybody can just override it, and it needs to be one or the other, in my opinion.
Okay, thank you for listing those off. I'm going to work backwards. So the assessment is important. It's obviously super important to help us determine the skilled care needs of an individual. There is not a specific assigned weight. We've talked about that several times, as you know. But it is important, and I hear you that perhaps we can use one of our escalation processes or come up with an escalation process specific to if the assessment had a huge miss in some way. And so let us take that back and talk about that a little bit further. We have the other processes in place. There's ways to reach out to both HIGPUF and to Telligent directly with questions around this, but let me formalize the process and get that out ASAP. Your middle question was around, maybe I shouldn't have had you list all three, just kidding. The middle question was around care plans. Yes.
Yeah.
Yep. So that process isn't changing. Home health agencies and case management agencies are still required to conduct the same process that they always have for care planning. Yes, they will take this information. Yes, they will want to absolutely read through what the assessment said and found to make sure they are seeing and addressing the needs of the individual in the same way. However, they're still responsible for creating their own care plan. Home health agencies must get doctor's orders. They must follow all of the documentation requirements. This is just another component of it. So none of that changes. Case management agencies are still required to go through the entire person-centered support planning process, which encompasses everything. And this is a piece of it. And this is information that they, again, should be reading, should be reviewing, and should be aware of all of the information in there. But they would not, it's not the only thing that they're going to be doing. This is not the one thing that they have to have in order to complete a care plan. And it doesn't change their process. It's the same. This is just another piece of information for both the home health agencies and these case management agencies. So hopefully that is helpful. Then continuing to go back around the duplication of the services question. So what happens if they find something that is filled out in the intermittent nursing, and then also the PDN section, a little bit here and a little bit here. How are they going to determine that? So a big part of what the nurse assessor is going to be doing is conducting education with the members and saying, hey, here's what we found. This is why they're walking through the assessment. Here's what you qualify for. Here's what we're looking at. Let's talk through what these different services are. What's the best way for you to receive them? Are you already receiving services? Sorry, somebody came off mute for a second. And how do you want to continue that? And so really, they're not going to have, the member isn't going to elect to get both, but the nurse assessor is going to guide them in the conversation to say, how do we want, you qualify for two, what makes the most sense for you? And then be able to translate that over. So hopefully that helps answer that question as well.
Yeah, I guess it's the HMA question that comes out of that where I get stuck. So if HMA is 56 plus 17.5 plus 2.5 hours for 28 visits all added together, then HMA is duplicating those, which I guess ends up being in the member's favor of more hours, but you get what I'm saying there, that there's some overlap between these things. So how are they parsing that out to say, you're choosing HMA, this is what HMA actually looks like. You're choosing PDN, this is what it looks like. You're choosing intermittent nursing, this is what it looks like, especially for HMA with how all the 3 tabs on the skilled acuity actually equal HMA.
Yeah, and it's, again, they're going to be having those conversations with the member and saying you chose HMA, and the case manager is going to have to, if they get this assessment and the member says, hey, I want 20 hours of HMA and 20 hours of CNA, those numbers don't add up, but don't worry. We're not using real math today. I want those 2 things. The case manager must also continue to do their job like normal and make sure that they are not authorizing services that are duplicative. And so having this information around the skilled care is going to be super beneficial. They've never had that before when it comes to children in particular. And so this is going to be really helpful for them in making sure that they are not authorizing duplicative services.
Okay, so the HMA number that will be on the recommendation will be CNA plus PDN plus 2.5 times the intermittent nursing visits.
It'll be all of it combined, yes.
Okay.
If that's what the member chooses, yes.
Okay, thanks.
Yeah. All right, let's take 2 more questions on this and then we can move forward. Jessica.
Yes, thank you. I will be quick. My first question on the recommendation letter, just clarifying to make sure that nothing changed. Let's say someone is currently receiving HMA, but they also access skilled nursing because there is a certain task that the attendant is not comfortable doing or the client's not comfortable with the attendant doing. That will still be allowed, right? They could have
Correct.
skilled nursing and HMA. Okay, perfect. Thank you.
That is
And then
correct.
second question on the direct services calculator really quick. We are starting to see quite a few different versions coming from case management agencies of those calculators. It seems like they're making their own. And then there's one that's branded by HCPF, but like it says, we're not going to give you the HMA total because that's coming from the nurse assessor. But if nurse assessor is delayed till 8/1, do you guys know, is that coming from the department? Or I have examples I'm going to be emailing over to you guys, but I've seen about 5 different versions now of the calculator. And this week alone, there was 3 examples what came up of them saying that they weren't going to give us the HMA breakdown because that was on the nurse assessor. But we're talking for clients that are 8/1s, 9/1s. And my understanding is that we shouldn't be waiting for the nurse assessor to process those 8/1s.
That is correct. And the interim direct service calculator is actually posted online. So there is one version. If you could send that to us and let us know. And as you were coming across different versions, if you could let us know, that would be super helpful so we could follow up with those case management agencies directly.
Perfect. I'll get you guys an email by end of day tomorrow.
Thank you. That's great. There was one other hand up, but it's gone now. So unless you want to re-raise your hand, going once, going twice. All right, let's move forward in our presentation. Thank you. Okay, so this is a big one that we actually were just talking a little bit about, kind of in a roundabout way, but how do points translate to time? So we're going to walk through how points are translated to time, starting with private duty nursing, then we'll talk a little bit about long-term home health nursing, and then we'll talk about CNA. Okay, so private duty nursing tasks. As you can see, the tool determines the total service hours needed through a point system. So each final point from the tool actually equals 15 minutes of care. And so here is a walkthrough of how you arrive at the total point value. So each task was assigned a number of minutes. Once the frequency of that task is selected in column K of the assessment tool, the tool then calculates the total number of hours per day, and that goes for that task in column N, so time divided by 60. I'm not going to walk through all of this math because I've clearly demonstrated that today is not a math day for me. But then you can see it walks through where the hours are listed, how it's all divided. And then there is actually a fact sheet that is super, super helpful that is posted online. It's linked here as well. I'm sure we can add it to the chat here for folks that, because remembering this and then going on to the other section and then on to the other section, it's just a really helpful reference point to walk through. Okay, exactly how is this math done? How is this calculated? So you can refer back to that. So this is how PDN tasks work. Next slide, please. Okay, so for long-term home health RN tasks, this tool is based, it's, the pediatric assessment tool. And the skilled nursing visits are based on frequency of care, not the length of time to complete the task, because this actual benefit is visit-based, not time-based. It's a whole thing. The total output is actually visits per day, not time per day. So this one's a little bit different. It's a little bit wonky and a little bit harder. But initial skilled nursing visits are actually assumed to be 2.5 hours in length. Thank you, Cassie, for posting that. And again, the logic fact sheet is super helpful with walking through all of those. Next slide, please. Okay, so CNA tasks. CNA tasks, so there's 3 different sections within the CNA tab, if you will. There's the CNA tasks, which include bathing, dressing, eating, medication, personal hygiene, range of motion, respiratory care, toileting, positioning, transfers, and vital systems, because I can read today, just can't do math. And so those are the actual CNA tasks. And then you have modifier A, which has the inclusions for communication, cooperation, neuromuscular status. There's the calculations for how that works, the range of points and how much time it equals. Then you have modifier B, which is for airway status, hearing, vision, pain, seizures, skin, and breathe and score. And again, there is the breakdown for how those points equate to time. Again, this comes from the pediatric assessment tool. So this information and these points are not new. Next slide, please. CNA continued, so that's why I moved on to that one. So, and then for CNA tasks specific, those that I listed in the last slide, here's how those points equate to time. Now, here's the kicker. You have modifier A, which if you recall, was a list of things that including communication and cooperation and things like that, plus if there are any identified modifier B, so airway status, hearing, vision, those types of things. So you add that time plus that time, and then also the CNA hours, which are listed here. And then you multiply that by 7 to get the total hours per week. Modifier A and B are only added if CNA tasks are identified. So only if there are CNA tasks, then do you add the modifiers. And the modifiers are because oftentimes communication, pain, cooperation, those things complicate those CNA tasks. And so those are additional time to add on for those reasons. So those 3 sections are added together to get your CNA hours. And that's how the points are broken down into hours. I knew I was waiting. I was taking a nice long deep breath because I knew there would be a question. Chris, how can I help?
Well, I'm not sure this was the question that you were expecting, but I'm wondering how
That's
for
okay.
adults the home health cap figures into this nurse assessment.
Yes. So for those of you who are not aware, there is actually a daily cap for amount of money when you're talking long-term home health, and then it's hours when you're talking PDN. That information is actually part of the training and what Telegen, Alma said Essentra knows too, because they do the parts, but Telegen must incorporate into the recommendation letter. So if somebody is assessed for 24 hours and it's PDN, the recommendation can only be 23 hours. Good question, though.
Okay, thanks, Candace. Appreciate it.
Yeah, of course. Other questions around this? Hopefully this is helpful. And again, this will be posted, so it's not going away. Deborah.
Okay, so I'm still really struggling with this math. So we're basically putting together PDN, which is task per time, and then the long-term home health skilled nursing, which is frequency per time, and trying to come up with a task per time for HMA. So I'm just, it's really convoluted and it's not making a lot of sense. Why wouldn't we just say, okay, we're going to go through and do a skilled acuity assessment. Yes, indeed, we're finding that there is a skilled need. Let's go ahead and just enter the HMA on the direct services calculator in the HMA section, calculating time per task. And indeed that it meets HMA criteria, because we're basically taking the pediatric assessment tool and the PDN tool, merging them together, which is the long-term home health. But really, HMA is its own entity, right? It's really
HMA is skilled care. It is so HMA is a delivery option of skilled care,
right,
which is CNA nursing care, right? And so it is not a separate assessed type of task because it is a skilled task. And so in order to be consistent for skilled care and the assessment of skilled care, we need to use the same tool. And so that would be the reason for not then moving on to a different tool for HMA.
Yeah, it just doesn't add up very well. What about personal care and homemaker pieces? So if the nurse assessor goes through and determines all of these tasks are skilled, and for example, maybe bathing isn't skilled for this kiddo, a lot of other things are, but bathing's not. So they will still in their recommendation then say, and nail care is another one, shaving's another one that, you know, typically are kind of on the fence for being skilled and not for every patient. Will they be skilled when other things are? So will they then have the personal care pieces listed on the recommendation as well?
Yeah, so if unskilled tasks are also identified, they will complete the direct care services calculator. so that they can then provide that information to the case manager for saying, for them to do the prior authorizations. So they can say, hey, we identified 10 hours of skilled care that are necessary. Here's what the member is chosen. This is what they would like. Let's say it's they want CNA services, and then they also have some unskilled personal care tasks or homemaker tasks even. They would then send that information to the case manager, all of it together so they understand. And then there's additional 5 hours a week of homemaker tasks that then the case manager would work with setting up for the member as well.
Okay, and then one last question, and this one's
Sure.
kind of tricky. So HMA is obviously nursing level. So you have a parent that's comfortable doing all of these tasks, medication, there's a trach and they're doing trach care, their kid's vented, they've got a G-tube, et cetera, titrating oxygen. So during the day, they have IHSS, and that's what the parent decides to do. Can they then also have a PDN at night and have them, so the kid needs pretty much 24-hour a day care, if you will. So we've got the hours for the HMA for parent, and then we have the hours that have to be a skilled nurse to be able to perform the tasks because they're skilled nursing. How do we do that?
Yeah, there can be two different agencies in providing the care as long as it's not duplicative. And so if we're talking IHSS and private duty nursing, as a for example, all of the case management agency, the IHSS agency, and the home health PDN agency all have to be in communication and documenting, okay, we're going to provide services for the first 12 hours a day, you provide services for the second 12 hours a day. And it's just, there has to be some really clear coordination, but you can absolutely have two different agencies in to provide that total care.
What if it's the same agency? So I'm employed.
It could be the same agency, and that works too. Yeah, that is totally fine too, as long as there is no duplication of the services, clear documentation of who is providing what and when, and then it's perfectly fine as well.
Okay, yeah, it would actually probably be best for that to be one agency because they can best coordinate that and make sure there's not duplication and that it's clear.
Yes. Yeah, I mean, for sure, that's ideal. Unfortunately, that's not always what works, right? Not everybody has the staffing pattern to be able to do that. But yeah, if it's one agency that can staff it, awesome. As long as, again, it's all about documentation and making sure that there's that clear coordination and everybody is on the same page for who's providing what, and then there's no overlap or duplication. Good question. I like that. Let's see here. Who was next? We have Irina.
Hi guys, good afternoon. Just quick questions or clarification. So it looks like for the skilled nursing visits, we try to be in alignment with the per visit approach, right? Which aligns with the Medicaid reimbursement for home health, long-term home health per visit. With the CNA, if we look at the rates, right, and reimbursement, it also goes per visit. So now here we introducing that per hours model, which makes it sort of inconsistent with the billing, approach.
Yeah.
So just, what I mean is just, even though we could easily calculate the visits into hours, but what I mean, we're trying to be consistent with nursing. There's some inconsistency with CNAs.
The CNA units are easier to convert to the hours because they are, for the first 30 minutes and then any 15 minutes after that. So those correlate much easier versus the nursing visits are 2.5 hours is the standard visit. And so I hear you. Yes, it's something we need to look at and make sure it's clear, and especially with our training.
Yeah. And then second part too, if I heard you correctly, you mentioned that, with long-term home health, the way we calculate points were very much based on the PET tool, right? Which would be pediatric specific. Was consideration given to, differences maybe that would correlate to, adult patients as well? Because there's no separate tool for that we used before.
Yes, absolutely. So part of, and that's a great question. So it was the pediatric assessment tool, which was a great tool that was developed many years ago. What we did was when we hired the University of Massachusetts to help us create a new tool, they took that component, also looked at components for adults because it is different for adults, as you know, and then created a brand new PDN tool. I do know that there was a comment earlier that said we just took the PDN tool and the PAT and put it together, and that's not entirely accurate. We did not use the current PDN tool. A different tool was completely created. Did put it with the PAT and then also added the components for the adults as well. That was a big part of what they had to do in order to put together a final assessment.
Thank you, Candace. Appreciate it.
Yeah, you're welcome. Thank you. Great question. And my apologies. I completely skipped over the home health agency with their hand raised, and I went straight to Irina. I'm so sorry for that.
Hi, can you guys hear me?
Oh, I can. Hi there. How are you?
Good. How are you?
Great,
Okay,
thanks.
so my question is, it's not related to the calculations and whatnot. It's just a general question, and I'm just wondering, throughout the several meetings I've participated in, if any of these changes are going to happen. Since you continue to bring up that the HMA is a skilled care, a type of skilled care, is there going to be in the future changes to the requirements to things such as the hiring criteria, documentation requirements, quality standards, supervisory requirements, which currently are required within long-term care? Because, you know, you continue to mention HMA is skilled care, but as a home health agency, we are functioning and have a lot of other higher requirements and standards that we have to follow. So my question is that going to change in the future for the HMA agencies that have the HMA?
Right. So the answer is no. Just so you know, and I hear you, you have different requirements, you have licensing requirements and all the things you have to follow, which IHSS must also follow. They have to provide backup care. They have to have oversight, things like that. But no, the Nurse Practice Act in the state of Colorado is waived for consumer-directed attendant support services, and that in with IHSS and for HMA. So that is how we are able to get unlicensed individuals allowed to provide these services. There's a lot of different things, and I will tell you, CDOS participants will tell you that it is not easy for them either. They have a lot of rules they have to follow. They have a lot of training that they do. They have a lot of things that they have to do in order to bring attendants on board to appropriately help them manage their care. But the short answer to your question, is it going to change? The answer is no.
Okay, so a follow-up.
That is Colorado law.
Okay, so follow-up to that is, if, for example, you have a patient that is adamant that they don't want an unskilled worker, you know, providing care, which you're saying they can under the HMA, and they want to stay with long-term home health, you know, where people are appropriately trained, you know, whether that's through schooling or certification or whatnot, do they have the choice?
Absolutely. Members always have the choice.
Okay.
So that is, thank you for asking that question. We've been asked that several times, and it is actually one of our frequently asked questions, but members always have the choice. So the nurse assessor is going to provide education, and they are going to help members and their families understand and know what their choices are, how they can get those skilled care needs met. They are never going to tell them how they have to get those needs met. It is 100% up to the member, and you know, if they have a family, or if it's pediatric, their family, to determine how they want, because self-direction is not for everybody. It is not the right choice for every single individual, and that's okay. But it is the right choice for many people, and that's also okay. And so it is 100%, 100% the member's choice. And it is not, the nurse has no benefit to guide somebody one way or the other. For the nurse assessor, their goal is to make sure the members understand their options so they can make an informed choice.
Okay, thank you very much.
Absolutely. All right, I'm going to take the next two questions, and then I'm going to move us forward because we have about 30 minutes left, and I still have a few slides. Molly, how can I help?
Good
Hopefully I can
morning.
help. Let's try.
Yeah, I think they're pretty quick. So on the topic of the 16-hour-a-day limit per caregiver, is extraordinary cleaning included under that 16-hour limit? under the CES benefit, extraordinary cleaning, the new enhanced homemaker benefit?
So the 16-hour limit is per day per caregiver.
Right.
And so extraordinary cleaning, I cannot imagine a single situation that anybody would be cleaning for over 16 hours in a single day.
No, not that, but is that whatever is authorized for extraordinary cleaning, if there are other direct care options authorized, if that's the same caregiver, is extraordinary cleaning in that limit?
No, it is not, and it is by service.
Okay.
It should be not by service, but it is. Yes. But no, it is not included in that.
Okay. When you say by service.
Yes, Cassie, jump in if I'm wrong, but it is 16 hours per service, which is not the overall intent. The idea is, and there's Department of Labor standards, right? And that's where we got the 16 hours. It applies to the private duty nursing benefit as well, that somebody shouldn't be working for longer than 16 hours in a day. That's when you start to get into some safety concerns, overtime. There's just a lot of things that can happen when somebody works. And so Cassie, correct me if I'm wrong on that one, please.
I don't think we've ever heard it termed that way, because when you say service, in IHSS, caregivers doing potentially 3 different categories of services.
Yeah,
and
Molly,
there she is. I was like, where is she? I can't even see her face.
So Molly, I think what we mean is these regulations are within personal care, homemaker, long-term home health, and private duty nursing. So those services combined.
Gotcha. Okay.
Are the services, for example, you're right.
Okay, so I said it wrong. So you're right, Molly. I said it wrong. My apologies.
If someone's doing extraordinary cleaning, let's say we're talking a parent caregiver, they're doing HMA, personal care, homemaker, extraordinary cleaning. It really should calculate all of those things together. We don't want to see someone working over that 16-hour limit, but technically that extraordinary cleaning does not go into that 16-hour calculation. So it could be 16 hours of personal care, homemaker, and long-term home health. And then they could work an additional 2 hours a day under extraordinary cleaning. It's not included in that calculation.
Okay, that answers my question. I do have one more quickie. I know that case managers have a little flexibility in authorizing some wiggle room from the nurse assessor's recommendation. Is there a scenario, for example, if someone is getting unskilled IHSS services, so personal care and homemaker, and then suddenly the member has a complex, or not even complex, suddenly they have medications they need to take, and maybe it's an hour a day and they're wanting that under their IHSS care plan. Is that 1 hour a day revision, does that require a nurse assessor? Or is that something that a case manager will have the flexibility to authorize without a full nurse assessment?
Yeah, so that will not require a full new assessment as long as they are not changing the level of services they're receiving. So as long as they're not going from personal care IHSS to HMA suddenly, or they're not going from CNA to PDN. But if they need, because they have some complicated medications, they're going to add that under HMA. The case manager, as long as they can document it, and they must document it, they can add that hour.
Okay, so in that case where there is no HMA at all at that point, and you're adding an hour a day of medication.
If you are adding HMA, then you would need a nurse assessor assessment in order for the skilled care component. Yes.
Okay.
That would be a change of condition. Yeah, great question. All right, Casey.
Hi, can you hear me?
I can.
Awesome. My question is, if you have a patient who is wanting to do CNA services, occasionally the PAT tool doesn't really reflect the need. Like, say they only qualify for like 3 hours of CNA, because for G-tubes, you get like the 4 points or whatever it is, but they have G-tube feeds every 3 hours. We were able to extend extra hours to them due to complexity of care, or the frequency of the G-tube feeds, give them some additional time. Will there still be that flexibility considered from if the agency is requesting that? Okay, that was really
so there is going to be an opportunity on the front end. So let's say the assessor determines that the tool did not appropriately capture all of the G-tube feeds, if you will, or all the time necessary. They can add that in at the end. and then provide the rationale for it. If for some reason it still doesn't capture it, you as the home health agency, as long as you have the appropriate supporting documentation as to the need, can submit for an additional hour, whatever it is, right? And then that will go through the medical necessity review. And as long as it is medically necessary and appropriately documented, it can be authorized.
Awesome. Thank you so much.
You're welcome. All right, let's move forward in our slide deck here, please. Okay, so expedited assessment. So this was the criteria that I mentioned at the very beginning of the presentation. This was part of the criteria that we had actually gone through with you all quite a few months ago. I won't say quite a few months ago because it wasn't that long ago. And so we determined what criteria would need to be met in order for an individual to be considered in need for an expedited assessment. So an expedited nurse assessment is really to help with those urgent referrals, things where somebody can't wait. We need it done very quickly. Thinking urgent medical or safety needs, caregiver breakdowns, or there's an immediate risk of health or a function that would be necessary. Next slide, please. So here is the key criteria that was identified. So this will be used by Telegen in their nurse assessor process to determine and to guide folks into either the standard assessment or into an expedited assessment. So these are the key things they're going to be looking for in the referral process. They're going to be asking questions. When they do the initial call, this will help them understand this. So acute medical conditions, high risk health concerns, social determinants of health, family crisis or breakdown, and urgent needs. So these are going to be the key criteria that will determine the need for an expedited assessment. I anticipate we have questions on this, so I want to take just a couple of questions because I really want to make sure we get through the rest of the slides, and we only have about 20 minutes. Are there any questions on this? So all right, then we'll just move forward. Okay, transition timelines. So this is another one where I mentioned it at the beginning, said I would go into a little bit more detail. Here's a little bit more detail. Okay, so members that have active PARs, so think adult long-term home health, private duty nursing members that have their PAR that are going to be ending in that little block of time that I like to hold up a block pretending like they fit into this little square or rectangle I'm holding, of August 1st through August 10th. Those members have actually been identified. We've pulled a list to be included in the ramp-up process. Home health agencies that have cases that meet this criteria actually received a very specific email with guidance on how they're going to move forward with these particular individuals so they do not lose or run late or run into any issues with the timeline for an August 1st. They actually will start during the ramp-up period of July 21st so we can get those PARs in place without any lapse. We also identified that pediatric long-term home health PARs starting August 1st are required to be submitted at the rate of 15% of the home health agency's caseload per month. How you submit those cases is completely determined by the home health agency. You come up with your own process and you determine who is going to be in your 15% each month going forward. As long as you are submitting 15% each month, yes, we are tracking it, just to be clear, so you know. We tracked it extremely closely for the soft launch for the therapies. We will be tracking these PARs as well to maintain and make sure that you are actually submitting 15%. You're not, you'll receive specific outreach from us reminding you. For any new members, home health agencies will need to assess if the member meets the criteria for expedited assessments or can utilize acute home health services. And then if the member does not meet acute home health services or expedited criteria, then the home health agency can actually discuss with the physician whether or not a delay in the start of care is safe for the member or not, and then get an updated order for the start of care. So those are some key timelines, some key transition pieces, if you will, that are going to be starting here in the next few months. Again, any agency that is part of the ramp-up period received a very specific email directly from us around training, with their list of members as well. So everybody has that list so they know who this applies to. And we are really excited to get going on July 21st. Next slide, please. Okay, so post-implementation monitoring, this is another big one that we've been asked several times around about is what metrics? What are we going to be looking at? How are we going to be monitoring? How are we going to know when things are going well or not going well? So these are the key areas that we are going to be looking at. I want you to note if there is something missing and that we can measure it and you think it's worthwhile. We are absolutely open to feedback and suggestions. I'm going to walk through this real quick first, Katie. So this is not an end-all be-all. If there are additional suggestions, we're happy to do so. We also are committed to posting publicly data and information where we can. As you all know, we can't post anything with any numbers under 30, safe harbor. There's all kinds of rules around that. And so we will be posting the information, all of the information that we can publicly as often as makes sense. It's not going to make sense for us to try to post something on July 22nd because there won't be enough data and we won't be able to post anything. And so we also will be posting information publicly. So here's the list of the metrics that we are going to be tracking. I'll let you all read it. I don't think you need me to read that entire list to you. With that, Katie, what's your question or comment or feedback?
Thanks. I had two questions here. One is, it doesn't look like we're going to look at the variance between what someone got before the assessment and what they got after the assessment to sort of judge or analyze.
That last one. That is the last one. So if you read all the way down, we'll also be monitoring variances between nurse assessor recommendations and PARs for benefits. So this is actually going to be the before and after. So we will be monitoring that.
Oh, this isn't like what the nurse assessor said, what the HHA requested and what the PAR actually was. It's also going backwards.
Yeah, we're also monitoring the variance in particular around what they had before and going forward. That's not clearly listed there, is it?
Yeah, I was just, when I read this before the meeting, I was surprised because this is a completely new assessment, it seems like we should be gathering data to make sure the assessment is doing what we want it to be doing. And I didn't see that in here.
Yeah, I see what you mean, and we will get that corrected.
Okay, and then the other one is, it doesn't seem like there's any analysis of appeals, which I think can be a pretty good indicator of the health of a system. So if there's a huge number of appeals of people because their PARs were rejected or because they don't feel like they're getting the hours that they need, that indicates lots of things about how this is working. So I would definitely add that as well.
Okay, I appreciate that feedback. Analysis of appeals. The only problem with appeals is, and not that it's a problem, it's the time lapse is really because it takes so long to get to that process and that information over to us versus this information we have a little bit more real time. But
well, even the filing of appeals, even if you didn't have the outcome, would indicate like, oh wow, there's a huge uptick in filing, and that would be right.
Those are still usually at a minimum 30 to 90 days out is the point. But yeah, I hear you, and that's something we can certainly take a look at too.
And then the other one I had was about, I know that there was in one of the presentations, if there's a variance with 6%, the nurse assessor does something. If it's 5%, they do something different. I think that's another data point that I would gather and report out on. Because I wasn't seeing
that was specific to HMA. Yeah, that was specific to HMA and
only HMA.
Correct. That is specific because that's when they would trigger them doing the direct care services calculator in addition to the assessment. So that's the difference there.
Okay. And then do you have a commitment until like how often this will be shared?
I don't until I know what the data shows and can understand what the numbers are going to look like. I cannot guarantee any sort of posting because then I get into some real serious PHI and HIPAA issues. I have a commitment to monitoring this. We actually have a dashboard that I will be looking at very frequently, and I will get it posted as soon as I have numbers large enough that I can post the information. And it may be piecemeal, like maybe I have number 5 before I have number 1, right? And I don't think that will be a problem. But I cannot, until I know what this data looks like and what these numbers start to look like, I can't promise quarterly, monthly, biweekly, anything like that just yet. But I will know that fairly quickly. There is, and there are issues with HIPAA when you have numbers that are less than 30, actually. That is a safe harbor law that we are not allowed to post any sort of number, no matter what, when it's under 30. So, Molly. Oh, I'm sorry. Katie, did I get all your questions? All your things? Sorry, Molly.
Yeah, thank you.
Okay.
No
Okay.
problem.
Sorry, I just want to make sure you were finished.
On the topic of 15% submission, because all of those submissions have to first go to the nurse assessor, and then it's possible that the member pivots and chooses self-direction. Are you tracking 15% of nurse assessor submissions or 15% of actual PAR submissions to a Centra? Because it's hard to kind of, I mean, you can have a good idea, but your 15% nurse assessor referrals may not equate to 15% home health PAR submissions.
Great point. Not surprised that Molly had a good point like that. And we were looking at PAR data, PAR submission, and so perhaps we need to look at a way to refine that a little bit. So let me take that back. Great point.
Okay, thanks.
Irina.
Hi again, Candice, and I did send you email with part of the question that I'm asking right now, but so now it seems like, we recognize the fact that not everybody is going to be eligible for acute long-term adult home health, right? And again, going back to regulations, it says specifically that long-term home health services can be provided on the first day if the clients have well-documented chronic needs and do not require acute episode. Is it possible to not have the client have a delay in services that could be crucial to their well-being in the expedited assessment criteria include this as an option, so that agencies could have their clients qualify for long-term home health on the first day when it's applicable?
Yeah, one of the expedited criteria is actually, I was just pulling it back up here, is around needing immediate access to care to prevent a lapse in care, so urgent needs. And so that could be a qualifying factor as well for an expedited assessment.
So if that's the case, if the provider has a client who qualifies for long-term home health on the first day, they could just describe that appropriately just to make sure that they can get expedited nurse assessor.
Yeah, correct.
Okay, perfect. Thank you so much.
You're welcome. And I'm going to take one more question on this and then move forward because we are very quickly running out of time and I still have a couple more slides I want to get through. So Chris, go right ahead.
Thank you, Candice. There's one thing that I do not feel that I am confident I know the answer to here at all, and that has to do with if a member is also on a waiver, and it has to do with coordinating the CFR with the date of the PAR. So I'm interested in to whom do we, or how does it work that you get either referred to a case management agency to have them send it to the nurse assessor because it's part of their process, or does the home health agency refer it to the nurse assessor first and then it goes to case management? How does that work exactly?
So it depends on the service. If we're talking health maintenance activities, if we're talking HMA, then as part of the CSR process, the contingency review that the case manager does, they're going to submit the referral to the nurse assessor. If you as a home health agency are providing the CNA services and let's say nursing services intermittently, then when you are ready or getting ready to submit your PAR or getting all those things in place, you would submit the referral to the nurse assessor. As far as the alignment of certification dates and the PAR dates for long-term home health, that would be nice. That's ideal for everybody. It's not always going to be possible. It is not required. We did submit or provide a list of members with their certification end dates to the home health agencies for the members they are serving, so that home health agencies could align it where it would work for them. But it is not required, and it is not always going to work out perfectly, unfortunately.
So Candice, you had talked about if a home health agency is providing a long-term home health service, but what if we're providing a long-term home health service to someone who also has a waiver and a CSR at the same time? If we're trying to make that happen, would that go to the case management agency and they would collect the information about the long-term home health as well? It seems pretty darn complex.
Yeah, so if, so are you asking, would the recommendation letter go to the case management agency?
No, I'm asking who sends this to the nurse assessor? Does the case manager have to take into account things that aren't health maintenance activities, but things that are long-term home health activities?
No, that would be the home health agency. The home health agency in that scenario is the one who's going to submit the referral. It could be both, and that's okay too, because the system isn't going to do duplicative assessments, and it'll identify that there were 2 referrals. But no, the case management agency does not have to submit the referral for long-term home health services. That would be the long-term home health agency that would submit that.
Okay, perfect. Thank you so much.
You're welcome. All right, let's move forward because we have 9 minutes, and I have a few more slides. Okay, so some frequently asked questions that I find super helpful to go through, because I think to the point of the name, I lost my mouse. To the point of the name, they've been asked a lot. Okay, so the very first one here is, does a member use Qualitrack to select a provider agency? No, they do not. That is not what the platform is for. They would actually go through a different system. They could use the regional accountable entity, the RAE, for assistance if necessary, but that is not what this system is for. Do referring providers receive notification via email or an in-portal alert when key events occur? And the answer is yes. They will receive notification for all of the events, contact with a member, scheduling complete letter, and then it skips over in cases where a member chooses to reschedule or receive an email. When they elect to receive their contact via email, that information, that simple election, doesn't go to the agencies. All right, next slide, please. Is there an appeal process for home health agencies if they do not agree with the nurse assessor recommendation? No. The nurse assessor recommendation is not a determination of medical necessity. It is not a determination of services. It is strictly a recommendation. It is strictly an assessment. If additional services are necessary and can be justified, they can be authorized. So it is not a denial or an approval of services. It is only a recommendation based off of an assessment. If additional hours are denied that are necessary, a member can then appeal once the denial is issued from Accenture or the case management agency. Here's the next one, is a good one that we've gotten a lot, and in fact earlier today. What if the nurse assessor recommends services through HMA, but the member insists that they want to receive those services through a licensed CNA RN? Can the member request it? So to be clear, the nurse assessor is never suggesting or recommending that a member receive something through HMA, one delivery option over another. They are solely going through, here's what your identified needs are. Here are the different ways that you can get your needs met. They are only receiving education. The member always has the option on how they receive their care, and it is always their choice. Next slide, please. All right. Can a referring provider agency submit a new assessment request in the Qualitrack portal for a member who is not yet on the agency's roster? Yes. Even if the agency is not officially providing services of care yet, as long as the member has Medicaid, they can submit a referral in the system. And then the next one is, how long is the assessment good for? We get this one quite a bit as well. If they have the assessment completed on 8/15, how long do they have to submit it? 90 days, 365 days, how long do they have to submit the PAR? The member is actually going to require a new assessment each certification year, so make sure each year we need a new assessment. This is an annual process. And then after the assessment is completed, the case manager or the home health agency has 60 days. So really, because these are so specific to healthcare tasks and healthcare services and medical services, the assessments are good for 60 days, which is why a case manager cannot submit the referral and begin the process prior to 60 days before their start date. And then, will the home health agency get a copy of the skilled acuity tool? Yes, the case manager and the home health agency will receive a copy of the completed and scored assessment so that they can go through and walk through and see where the needs were identified, what was identified, If the member submits the referral on their own behalf, they must indicate who they want to receive that recommendation and referral form, or in the referral form, which would include the assessment as well. Oh, that was a lot of material. That was a lot that we just covered. We have time for probably about one more question. Cassie, is there anything that's come up multiple times in the chat that you'd like me to cover?
No, there's just one-off questions that I can
A lot of
see.
one-off questions. Okay.
A lot of one-off questions, but yeah, please, if anyone wants to raise their hand for the last couple minutes.
All right. I've got time for probably one question. Tara.
Can you hear me?
I can.
Can you just review really quick what it's going to look like if we have, let's say I have a kiddo that we provide CNA services for, but they are also on CES waiver services, and the CSR date and the annual date for our PAT don't align. I know that they're wanting those dates to align as much as possible. What does that look like? Is one going to have to complete either the annual or the CSR sooner than the other, or do you see what I'm saying? So like,
yeah.
Could it be sooner than, like if we had to redo our annual to align with the CSR of the CES waiver, then could it be that we're doing an annual 6 months out? Do you see what I'm saying?
Yeah, I know what you're saying. So there is not a requirement for them to be aligned. It is ideal for them to be aligned, but keep in mind that there are no prior authorizations right now in place for these pediatric members. And so you are going to have to submit, and so the PAT tool that you did will be redone by the nurse assessor, because it'll be the new skilled care acuity assessment that is completed. So you will have to have all of that process and all of that completed regardless here very soon. So if you have a member that has a CSR date where their certification date ends October 31st, then you have an opportunity to go ahead and submit that the nurse assessor assessment so that you can work to align your PAR dates for that pediatric patient with the CSR dates. If they don't exactly line up, or what have you, we're not going to ask anybody to move things, adjust things. We want it to work for your caseload, because what we don't want is, let's say you have 15 CSRs in December and somehow you end up with 45, something that's just unworkable for your agency as far as reauthorization. And so you want to be mindful of that too. So it is not a requirement. We provide that information to be helpful so that you can align it when feasible. Does that make sense?
Yep. And then just to kind of piggyback off of that, we have tons of families that can't tell us who providers are, who their service coordinators are, right? Like they just kind of are all up in limbo with all their services. So it's not uncommon for when I ask a family who their service coordination, who their caseworker is, and they're like, oh, it's TRE. Okay, but who's your caseworker, right? So when we submit these to the nurse assessors and they're providing this back to us and the case management agency, are we also going to know at that point who their case manager is, so we can also coordinate care on our end?
That is a good question. And so let me take that back and see if there's a way for us to help with that coordination. Because that's a good point, that not everybody knows the exact case manager's name, and it might be helpful for you all as agencies.
Or just, turnover rates or whatever the case might be.
Right,
but,
right.
Just an easier way for us to be able to manage services across all the people.
Okay, let me take that back and see what we can come up with. I'm going to move us forward because we are actually at time. So 2 slides forward, please. One more. So just a real quick timeline. There's some July dates, August and September. Things are going really smoothly. We're really excited. We're going to get started for the ramp up period starting July 21st. August 1st, everything launches and is live. And the next slide, please. And a huge thank you. Thank you all so much for your participation, your ongoing participation, your great questions. These are really, really important. We really appreciate you taking the time to ask these questions, to follow up, to, really learn this process. It is new. It is really exciting, and something that we know we're going to have to continue to work through, potential bumps, kinks, things like that. But please continue to send your questions, your comments, and you see the previous slide. Sure, we can walk back one slide real quick. Please continue to send your comments, your questions. Please take a look for our listening log, which will be updated with all of these comments and questions. And thank you again, and happy brand new fiscal year. It's after July 1st, which is exciting. And I hope you all are having a wonderful summer. And thank you again. Take care.